Hi, my name is Catherine Poulos. I'm a psychiatric nurse practitioner located on the east end of Long Island. And several years ago, I began to notice that around September, early fall, approximately 1 out of 10 patients would start to report depressive symptoms such as hyperinsomnia, increased appetite, especially for carbs, then weight gain, fatigue, and low energy, and a social withdrawal, which we call as a phenomenon of hibernation. But interestingly enough, these symptoms tended to resolve in the spring without any major intervention, but extremely uncomfortable for the patients for the duration of that period. So this pattern is characteristic of seasonal affective disorder, SAD, which according to the DSM-5 does not have a separate diagnosis, but rather an add-on specifier for major depressive disorder. Basically, it's depression with a seasonal pattern. Occurs at any particular time of the year, usually the fall and the winter, and remits in another time of the year, usually the spring or the summer. So as a clinician, I wanted to explore interventions that were effective yet natural, avoiding any drastic pharmaceutical or invasive options. This curiosity led me to investigate the potential of vitamin D supplementation as a means to improve the symptoms of seasonal affective disorder. So, as a clinician, I want to explore the evidence-based answer to the important question, what does the existing research say about vitamin D supplementation for SAD? I looked at the target population, adults with recurrent MDD, with that seasonal component of SAD, and patients also would have the subtherapeutic serum levels of 25-hydroxy vitamin D levels. So to investigate this, I conducted 4 literature searches using a combination of keywords. These searches yielded approximately 60 articles, from which 5 were identified as particularly noteworthy due to their strong methodology and clinical relevance. From this review, several key takeaways started to emerge. Randomized placebo-controlled trials showed mixed but promising outcomes. Meta-analysis supported the benefits of vitamin D supplementation in deficient populations. This implies that the correction of a deficiency can lead to a relief of symptoms. Vitamin D deficiency is a modifiable risk factor. What does that mean? Vitamin D insufficiency has been linked not only to depressive symptoms, but also to a variety of chronic medical conditions, including bone disorders, weakened immunity, and cardiometabolic diseases. So through sunlight exposure, diet, or supplementation, clinicians can help patients address a correctable biological vulnerability. The lack of standardized screening and supplementation protocols in clinical practice is another significant takeaway. Despite growing awareness of vitamin D's role in both physical and mental health, there is no universal screening for or dosing standards for SAD. This variability leaves many patients underdiagnosed and undertreated. As clinicians, we have the opportunity to make a change by integrating routine vitamin D assessment into our seasonal depression care plans. So why vitamin D? So let's look at why sunlight was such a powerful impact on the mood. As seen in the diagram, there are several biochemical steps through which UVB exposure is converted into compounds that enhance brain function and emotional stability. When sunlight reaches the skin, it triggers the conversion of 7-dehydroxycholesterol into vitamin D3. The sun is therefore essential in the endogenous production of vitamin D, which plays a direct and indirect role in the brain health and neurotransmitter regulation. So one key mechanism involves tryptophan, an enzyme found in the brain that serves as a rate-limiting step in the synthesis of serotonin. And as we know, serotonin is a critical neurotransmitter associated with mood, motivation, and well-being. So when the sunlight exposure decreases, such as during the winter months, prolonged indoor activity, or higher latitudes, the resulting drop in vitamin D levels may downregulate this serotonin activity, leading to reduced serotonin production. This biochemical cascade is one of the leading explanations for mood changes in the seasonal affective disorder, or SAD. So something also to consider is vitamin D has 2 different types. So for the purposes of this study, we're going to utilize vitamin D3, which is synthesized in the skin under UVB sunlight exposure or obtained from animal-based foods such as fatty fish, eggs, and egg yolks and liver. But just to take note, most multiple vitamins are vitamin D2, which is less expensive. So if I move on to the methodology of the study, in simpler language, I was looking for adults in New York who experience mild to moderate winter depression and have low vitamin D levels at the start of the fall and aren't making any of the treatment changes during the study. And there was multiple exclusions, of course, that were pretty standardized, but the inclusions were more correct. So if I look at the theoretical framework for this project, it'd be best understood under the health belief model, which explains and predicts how individuals make decisions about their health behaviors. The model is built around 6 main concepts: perceived susceptibility, perceived severity, perceived beliefs, benefits, perceived barriers, cues to action, and self-efficacy. In the context of SAD and vitamin D deficiency, each of these components applies in a meaningful way. Perceived susceptibility means many adults living in the northern climates, like New York, may not realize how vulnerable they are in developing low vitamin D levels during the fall and the winter months. Helping patients understand their personal risk, such as limited sunlight exposure or fatigue that worsens seasonally, builds awareness and motivation to act. Perceived severity means that seasonal depression is often minimized or seen as winter blues. By educating patients on how low vitamin D and reduced serotonin can impact mental health, clinicians can reframe SAD as a real biologically influenced condition that deserves attention and care. Perceived benefits emphasizes that the benefits of vitamin D supplementation, improved energy, mood, and stability, and better overall wellness helps patients view it as a simple, natural, and worthwhile preventive measure. Perceived barriers. Well, some patients may resist supplementation due to the cost, forgetfulness, or skepticism about its value. These barriers can be addressed through education, affordable supplement options, and regular follow-up and encouragement. Cues to action. Seasonal cues such as shorter days and colder weather can serve as reminders to check vitamin D levels or begin supplementation in early fall. Clinicians can reduce these cues through patient education, reminders, and annual full wellness visits. Self-efficacy. Ultimately, patients who believe that they manage their own health are more likely to follow through. Providing knowledge in simple steps like taking vitamin D3 daily, spending time outdoors, and monitoring levels empowers the patients to take control of their seasonal wellness. Viewed through the lens of the health belief model, this project is not only about improving lab numbers, it's about changing beliefs and behaviors around preventative self-care. When patients understand the link between sunlight, vitamin D, and mood, and feel confident that they can do something about it, they are more likely to engage and be proactive in their behaviors that support emotional well-being. Ultimately, my hope is that this kind of awareness will encourage more clinicians to routinely assess vitamin D as part of their approach in the management of seasonal mood changes. So let's move on to the outcomes. For this project, I decided to keep things simple and focused on 2 outcomes: changes in mood and changes in vitamin D levels. The structured interview guide for the Hamilton Depression Rating Scale, Seasonal Affective Disorder version, known as SAD, is a clinician-administered assessment tool used to evaluate the severity of depressive symptoms, specifically in people with seasonal affective disorder, SAD. Increased sleep, increased appetite or craving, especially for carbs, fatigue, social withdrawal, weight gain, are also monitored through that SAD. The vitamin D levels are also monitored for baseline levels and post-intervention, the percentage of achieving sufficiency, and monitoring for mean changes in labs. So the conclusion would be vitamin D supplementation is a low-cost, evidence-based intervention that reduces the symptoms of seasonal affective disorder, addresses a common mental health burden, decreases winter depressive symptoms, promotes preventative care, increases patient engagement and adherence, potential reduction in psychotropic medication reliance, and hopefully this encourages you to look at your patients a little bit differently during those winter months when they're coming in feeling not their ultimate best. Thank you.